Hi guys, good evening, good evening. Can you all hear me? Can you all see me? Right. If you're all joined up, tuned up, let's talk about few important questions from hernia, spleen and pancreas. So we'll go in the same order that we have described here, right? Can we start? So the first thing first, what are the questions that they've asked you in hernia? The questions that they've asked you in hernia is number one, a short note on inguinal hernia. They've asked you about the inguinal hernia. They asked you about, there's a collective set of questions where they asked you complications associated with inguinal hernia. Complications in hernia and its management. So they've asked you about inguinal hernia. They've asked you about the complications which are associated with the hernia and its management. Then they've asked you how to differentiate between indirect inguinal hernia and the direct inguinal hernia. They asked you how to differentiate between indirect inguinal hernia as well as direct inguinal hernia, right? So can you please later make an orientation class for upcoming fourth year? Sure, beta Nebula will do that. So don't worry about it, right? So these were the questions which are asked. We'll try to summarize them. A short note was for 5 marks. Complication was 5 marks. And there was this 5 marks. And there was one question where a combination of these two were given. That is difference, and then this was of 10 marks, right? So we'll try to give you a wholesome approach that if a question comes, how are you going to write accordingly? Clear? Right. So let's dig in with respect to the first one, that is going to be inguinal hernia, right? So we'll talk about the answer. So here the answer we are going to focus is going to be on inguinal hernia. Now in the inguinal hernia, so when you talk about any hernias, when you talk about any hernias, you need to know the basic definition of hernia, and then you move accordingly as we say across. So what is defined hernia? Hernia is defined as it is the protrusion of abdominal viscera. Protrusion of abdominal viscera through an abdominal wall weakness. Through an abdominal wall weakness. Through an abdominal wall weakness is what we define as hernia. It's a simple definition of hernia. It is the protrusion of abdominal wall viscera through an abdominal wall weakness is what we call it as hernia, right? Now, here's an important thing that when you talk about inguinal hernias, you should know a quick recap on the anatomy of the inguinal canal. So the next heading is going to be inguinal canal anatomy. So I'll tell you the easiest way to draw the inguinal canal and then represent it at the same time. In the inguinal canal anatomy, you need to understand the following components, right? So on the medial most aspect, you can draw a line which says this is the rectus abdominis wall muscle, right? So this is your rectus abdominis wall muscle, right? Now just undersurface it, this is your pubic arch, this happens to be your pubic tubercle, this is your pubic symphysis, and this is your pubic bone that is going to be present across here, right? So this is the orientation of the pubic bone. Now this is going to help me. I'll just take a little bit, change the rectus abdominis muscle. So should okay, I should have given the pubic bone first and then gone for it. Anyhow, so this happens to be your rectus abdominis wall muscle, which is right in the middle, and this is your pubic tubercle, which is going to be present, right? Now on the medial side, you see there is rectus abdominis wall muscle, right? Now look at the outermost part. The outermost part is going to be your external oblique muscle. So this external oblique muscle is going to come and it is going to attach. So this is your external oblique muscle which is going to be present. Now as it nears the abdominal wall, it is now going to convert into aponeurotic tissue. So this is your aponeurosis, right? So this is all your aponeurosis which is going to form here. Now this aponeurosis, as it comes closer to the inguinal canal, it condenses itself and forms an inguinal ligament, and that inguinal ligament is going to attach from the anterior superior iliac spine to the pubic tubercle, right? So this is your pubic symphysis, and you can see this is your external oblique aponeurosis, right? Now when you look at this external oblique aponeurosis, as it comes across here, the external oblique aponeurosis in this particular site, external oblique aponeurosis in this particular site, it is going to turn backwards like this, right? Now as it attaches, and it is going to flip on itself, so it's like turning on itself, right? It is going to rotate on itself. Now as it rotates on itself, it forms a small opening, and this opening is what we call it as the superficial inguinal ring. This is what we call it as the superficial inguinal ring. Now if they ask you what is a superficial inguinal ring, the superficial inguinal ring is basically a small defect that is going to be present on the external oblique aponeurosis. For the sake of understanding, those who have just joined, the first muscle that I've drawn in front of you, this is your external oblique muscle. This is going to be your external oblique muscle that is present. This is your external oblique aponeurosis. Behind the external oblique muscle, you have another muscle which is going to be the internal oblique muscle. Behind the internal oblique muscle, you have the transverse abdominis muscle. And behind the transverse abdominis muscle, you have the fascia transversalis. Behind this, you have the fascia transversalis, which is going to be present throughout, right? So this is the fascia transversalis, which is the posterior most muscle that is present. And that fascia transversalis, as you go across, will cover the entire abdominal component. Now behind the fascia transversalis, what do you have? Behind the fascia transversalis, the last layer that is going to be present inside the abdominal wall, this is going to be your peritoneum. So if you look at the cross section, from top to bottom, this is your external oblique muscle. This happens to be your external oblique muscle. This happens to be your internal oblique muscle. This happens to be your transverse abdominis muscle. This happens to be your fascia transversalis, and the innermost is going to be peritoneum. The innermost is going to be peritoneum, right? So when you look at the whole context here, you have the external oblique muscle, the internal oblique muscle, the transverse abdominis, fascia transversalis, peritoneum, and inside the peritoneum, you have your abdominal cavity. Now, if you have understood this basic orientation, I will just isolate the components so that you understand better. Now, the outermost surface, this is your inguinal canal, and I said it is going to flip on itself. Now, as it turns on itself, it is now going to create an opening here, and this opening is what we call it as the superficial inguinal ring. Now, this is the anterior surface. Posteriorly, what do you have? Posteriorly, you're going to have the fascia transversalis, and the defect in the fascia transversalis is what we call it as the deep inguinal ring. And beyond this, what do you have? You have the peritoneal surface. Now, if you look at, this is just for the sake of orientation, if you're not able to get a grip, this is the anterior surface and this is the posterior surface, right? So in the anterior most, this is your external oblique aponeurosis. This is your external oblique. This happens to be your external oblique aponeurosis, right? So defect in the external oblique aponeurosis is what we call it as the superficial inguinal ring. Now the innermost that you can see here, this happens to be fascia transversalis. Now this fascia transversalis has a defect, and this defect is what we call it as the deep inguinal ring, and the innermost layer that you have is going to be peritoneum. Now this we all know, right? Now what is going to happen? You will notice that in the inguinal canal, if you take this as a representation of the testes, right? This is the representation of the testes. You will find that the vast difference on the testes is going to arise. The vast difference arises from the testes, enters into the superficial inguinal ring, travels into the inguinal canal, exits from the deep inguinal ring, turns medially, and then it goes. So what is the journey of the vas deferens? The vas deferens is going to go behind the bladder. It is going to combine with the seminal vesicles. Together they form the ejaculated duct. They go into the prostate. In the prostatic urethra, they open, and the opening of that structure is what we call it as verumontanum. Right? यही journey है. तो पूरी journey कहाँ से शुरू हुई? Testes से शुरू हुई, vas deferens की, inguinal canal, superficial inguinal ring में enter किया, इंग्वाइनल कैनाल में गया, डीप इंग्वाइनल रिंग से निकला, एकदम यू टर्न मारा. जैसे ही यू टर्न मारा, इट इज नाउ गोइंग टू गो बिहाइंड द ब्लैडर. इट ट्रैवल्स बिटवीन द पेरिटोनियम एंड द फेशिया ट्रांसवर्सालिस, goes behind the bladder, combines with the seminal vesicle, forms an ejaculatory duct, opens into the prostatic urethra guarded by, or that opening is known as verumontanum. इसके साथ you will see there's another nerve that is going to be present. The nerve that is going to travel in the inguinal canal along with the vas deferens. This is going to be your ilioinguinal nerve. So two structures. This is going to be vas deferens. This is going to be vas deferens, and this happens to be your ilioinguinal nerve. This is going to be your ilioinguinal nerve, right? So these are the important structural component that you need to know. Is that clear? Right? So this is the anterior orientation of your abdominal wall, and this condensation that you see at the bottom, no, this is what we call it as the inguinal ligament. This is what we call it as the inguinal ligament. This is what we call it as the inguinal ligament, right? Now the attachment of the inguinal ligament is going to be from the anterior superior iliac spine, which is called as ASIS, and this attachment here is going to be with pubic tubercle. This attachment is going to be pubic tubercle. Sorted? Okay. So this is your first orientation that you need to keep with respect to the anatomy of the inguinal canal. So if they are going to ask you define the anatomy of the inguinal canal, I hope nobody is going to go wrong now. So if they ask you the anatomy of the inguinal canal, so this is how the anatomy of the inguinal canal will be described. Clear? Right? Now, once you have described the inguinal canal, couple of important points that you can tell, and in fact you can write it down, that the superficial inguinal ring, just for the sake of completion, the superficial inguinal ring is going to be triangular in shape, whereas deep inguinal ring is inverted U-shaped. Going to be inverted U-shaped. So deep inguinal ring is a defect in fascia transversalis. Superficial inguinal ring is actually a defect in external oblique aponeurosis, right? Metoprolol will tell you which surgery causes the damage of ilioinguinal nerve. It is the open inguinal hernia repair. Okay, so don't worry. So this is about inguinal canal anatomy. Now the another question that they asked you is comparison between the direct inguinal hernia and the indirect inguinal hernia. So we'll quickly talk about how would you compare between indirect inguinal hernia, indirect inguinal hernia. We'll have a comparison between indirect inguinal hernia versus direct inguinal hernia. Indirect inguinal hernia versus the direct inguinal hernia, right? So in the comparison, the first thing you need to know is the basic representation that we already did. We'll follow the same diagrammatic representation so that we don't goof up. Now, what is the representation that you have? You have the external oblique aponeurosis. This happens to be superficial inguinal ring. Now, in deep inside, you have, this is your fascia transversalis. This is your deep inguinal ring. This continues across here, right? Now, next you have your peritoneum. The peritoneum is going to be present here. So this is the peritoneal surface that you have, right? So this we all know. There is a structure that is going to travel. So I think we have used, okay, this is the color code. Now, this is the vas deferens, which is going to go in the inguinal canal and is going to enter from here. And this happens to be the ilioinguinal nerve, right? This has been our representation. We'll follow the same representation, right? So we'll not miss on this. So I'll just replicate it here so that we have, don't need to draw. Okay? So this is the comparison between the direct and the indirect inguinal hernia. So we'll quickly give you the basic differentiation. Now the first thing, you need to understand what are the entry points. So where does the entry point, where is the entry of the indirect inguinal hernia and direct? Where is the exit of this? What is the sac made up of? What is the sac made up of? what is the content of the hernia that you're looking at, and the relation to the surrounding is what you're going to look at, right? Now, in simple words, when you talk about indirect inguinal hernia, just to get the concept correct, indirect inguinal hernia, it so happens that you'll start exerting pressure. Let's say there's a bowel that is present, and that bowel is exerting pressure at the deep inguinal ring. Now, as the pressure continues to mount, what is going to happen? You will notice that this area is going to get widened. Now, under the influence of so much pressure that has been exerted, with so much pressure which has been exerted, you see the deep inguinal ring is going to dilate. Now, this dilatation of the deep inguinal ring is under the influence. It is under the influence of the pressure exerted by the bowel that is present here. So, it will push the peritoneum here. So, the peritoneum which is present here is now forced to go inside. Now, why is it forced to go inside? It all occurs because the bowel that is present here is exerting pressure. So, the intra-abdominal bowel that is present, that is exerting pressure there. Now, as the pressure continues to mount, what will happen? This peritoneum will travel via the inguinal canal. As it travels via the inguinal canal, it is now going to pop out, and this popping is what we call it as the hernia, that is sac. So, why it is going to pop? Again, this content which is present. Now, this content which is present here is going to travel along with the inguinal canal. It is going to travel along with the inguinal canal. It will go through its entire journey. It is now going to exit through. It is now going to exit through, and this is how the indirect inguinal hernia is going to be formed. So, in an indirect inguinal hernia, just for the sake of understanding, so that we all are on the same page, the green structure that we have drawn, this is the peritoneum. This is the peritoneum that is present, right? Now, this pink structure that we have drawn, we'll say this is the bowel. This is the fascia transversalis. We'll say FT, that is your fascia transversalis. This is your external oblique aponeurosis. This is your external oblique aponeurosis which is forming. This is your deep inguinal ring. This happens to be your superficial inguinal ring. This is your superficial inguinal ring. This is your vas deferens. This is your ilioinguinal nerve, right? So, this is how your indirect inguinal hernia is going to be formed. Clear? Now, for a direct inguinal hernia, there is a defect that is going to be present, or I can say abdominal wall weakness. When you look at, this is the medial side, no? There's a muscle which is present here. This is your rectus abdominis wall muscle, right? So, the muscle which is here, this is your rectus abdominis wall muscle. Now, from the external iliac, there is a blood vessel that is going to originate, and that blood vessel that is originating from the external iliac, this is your inferior epigastric artery. This is your inferior epigastric artery which is going to run. Now, you see there is this area between the inferior epigastric artery, the rectus abdominis muscle, and the inguinal canal. You see this area? This area is where it is not guarded by any muscle, and this is an anatomical weakness that is present. And this anatomical weakness is what we call it as the Hasselbalch's triangle. Right? So, the boundaries of the Hasselbalch's triangle is also very important. So, when you describe a direct inguinal hernia, you cannot describe a direct inguinal hernia without describing the Hasselbalch's triangle. So, this shaded part is your Hasselbalch's triangle. So, the anatomical weakness lies in the Hasselbalch's triangle. So, you see this is the medial boundary. The medial boundary is formed by the lateral border. It is formed by the lateral border of rectus abdominis muscle. Then this is the lateral boundary. The lateral boundary is formed by the inferior epigastric artery, and the inferior boundary, this is the inferior boundary, it is formed by the inguinal canal. It is formed by the inguinal canal. Now, this triangular area which is not guarded by any of these muscles forms an abdominal wall weakness. Now, once there is a weakness that is present, the same thing is going to happen. The bowel is now going to come and sit at this area. Now, as the bowel comes and sit across this area, it starts exerting pressure here. Now, as the pressure continues to mount, what is going to happen? As the pressure continues to mount, you see this area is now going to get deformed. This area is now going to get deformed. Now, how it is going to get deformed? Let's see, right? So, you will notice that as more and more amount of pressure is going to be exerted, see this pressure is in this Hasselbalch's region, right? So, this whole area is now going to transform. Let's see how it is going to transform. Right. Now, the first thing you notice that as the pressure mounts, the peritoneum is going to go down. This area will also go down. that is your fascia transversalis. This is your superficial inguinal ring. It is going to get dilated. Now, why it is getting dilated is, you see this fascia transversalis is now forced. The fascia transversalis is now forced to pop out from this region. Now, this occurs because of the pressure exerted by the bowel on the peritoneal surface. So, the peritoneum is also going to pop out through this. Now, all this is happening because of the abdominal wall weakness, which is explored by the bowel that is present here. So, you see the bowel that is present here is now going to go across here. It is exerting pressure. It could be bowel or omentum both, but just for the sake of easy explanation, I'm using the example as bowel. And you see the content moving inside and pushing the everything, right? The vas deferens is in its own position. The vas deferens is here. The ilioinguinal ring, nerve is going to be here, which is going to be present across here. Now, if you see the difference between the indirect and the direct inguinal hernia, this is going to be quite clear in front of you. In the indirect inguinal hernia, it is entering from the deep inguinal ring. It is exiting from the superficial inguinal ring. Whereas in the direct inguinal hernia, it is entering from the Hasselbalch's triangle and exiting from the superficial inguinal ring. Okay? So this is a small concept that many of us tend to forget, and we think, अरे इधर का उधर हो गया, इधर का उधर हो गया, हर्निया में ये है, डायरेक्ट और इनडायरेक्ट में क्या फर्क है, कुछ नहीं. बट डायरेक्ट खुद घुस रहा है. इट इज जस्ट कमिंग, इट इज नॉट गोइंग फ्रॉम एक जगह. देखो इनडायरेक्ट में क्या एंट्री कहीं है, एग्जिट कहीं है. यहाँ पे एंट्री एग्जिट एक ही जगह से मार रहा है, तो इट इज गोइंग टू बी डायरेक्ट इंग्वाइनल हर्निया. ठीक है. सो नाउ इफ द कॉन्सेप्ट इज क्लियर, आपको ये कंपैरेटिव टेबल डालना है. ठीक है. ये थोड़ा सा स्टिक डायग्राम बना देना और ये लेबल कर देना. वंस यू हैव लेबल्ड इट, ऑल दैट यू हैव टू डू इज एंट्री एग्जिट. अब आप खुद बता दोगे. ठीक है. So when I say entry and exit, let's analyze every single component that we have. Okay? Now, when I say where is the entry of the indirect inguinal hernia, the entry of the indirect inguinal hernia is going to be from the deep inguinal ring, whereas for the direct inguinal hernia, it is going to be from the Hasselbalch's triangle. Okay? So in some context, rather than saying Hasselbalch's triangle, you can also use the word the posterior wall of the inguinal canal. Exit दोनों का एक ही है. The exit is going to be from the superficial inguinal ring. Now this outer covering that is present, no, ये जो outermost covering that is present, this is what we call it as the sac of the hernia. sac के अंदर जो भी मिलेगा उसको आप content बोलते हो. This is what we call it as the content of the hernia. ठीक है. सेम यहाँ पे भी देखो, the outermost covering is what we call it as sac. sac के अंदर जो भी मिलेगा उसको आप content बोलोगे. ठीक है. This is the content of the hernia. Now when you look at the comparison between both of them, सवाल ये है कि sac किससे बना हुआ है, right? Now sac in the indirect inguinal hernia is made up of peritoneum. आप खुद देख लो, समझ में आ जाएगा. ठीक है. Whereas sac in a direct inguinal hernia is made up of fascia transversalis. It is made up of fascia transversalis, right? The sac, it is made up of fascia transversalis, right? So in your inguinal hernias comparison, the entry and the exit points are important, so you have worked it out. The sac, what it is formed, we now know it. What is the content? Based upon the content. Now if the content is bowel, this will be called as enterocele. If the content is omentum, this will be called as omentocele. सेम विल बी हियर. अगर कंटेंट बवल होगा आप इसको एंटीरोसील बोलोगे. इफ द कंटेंट इज गोइंग टू बी ओमेंटम, यू विल कॉल इट एज ओमेंटोसील. Now, based upon other words, we have like other structures, we can modify the name. For example, if the content is Meckel's diverticulum, it will be called as Litter's hernia. If the content is appendix, it will be called as the Amiens hernia, right? If you have both direct and indirect from the same inguinal canal, it is called as Pantaloon's hernia. So all these are special forms, but two common things, bowel and omentum. Bowel is called as enterocele, omentum is called as omentocele. Now, we have to see the relationship, that means between the sac and the cord. Now, when you talk about the sac and the cord, this is the medial side and this happens to be the lateral side. अगर आप indirect inguinal hernia में ध्यान दोगे कि cord यहाँ पे है और sac इसके lateral side में, तो sac will be present on the lateral side of the cord in an indirect inguinal hernia. Now come to direct inguinal hernia. Direct inguinal hernia में cord यहाँ पे, sac is on the medial side. ठीक है. So this is the medial side and this happens to be the lateral side. ठीक है. तो यहाँ पे आप देख रहे हो sac is going to be, it is going to be medial to the cord, and this is what you need to remember, that in relationship नॉट द वन दैट यू आर थिंकिंग। ये हर्निया का रिलेशनशिप है, वैलेंटाइंस डे कल चला गया तो आज पढ़ाई में कॉन्सेंट्रेट करेंगे। तो रिलेशनशिप वी आर टॉकिंग अबाउट हियर, इसे द सैक लाइज, it is going to sac lies lateral to the cord। यहां रिलेशन में आप बोलोगे sac lies medial to the cord, it is called the medial to the cord। now थोड़ा सा और अगर वाइवा में आपको परेशान करना है तो आपके एंट्री पॉइंट को ना, एंट्री पॉइंट इज ऑल्सो रेफर टू एज द नेक ऑफ द हर्निया, इट इज ऑल्सो कॉल्ड एज द नेक ऑफ द हर्निया। अब इसका रिलेशनशिप देख लो। Now remember the neck of the indirect inguinal hernia, neck lies lateral to inferior epigastric artery। यहाँ पे neck lies medial to inferior epigastric artery, to the inferior epigastric artery, right? So it is going to lie medial to that of inferior epigastric artery। कहाँ पे आपकी inferior epigastric artery? आप देख रहे हो कि inferior epigastric artery हमारी यहाँ पे है, this is our inferior epigastric artery, ठीक है। तो अगर आप inferior epigastric artery you know where it is, now we say that inferior epigastric artery का medial और lateral कौन सा हो जाएगा? This will become the medial side and this will become the lateral side। तो मीडियल से एंट्री कौन ले रहा है? मीडियल से डायरेक्ट इंग्वाइनल हर्निया, इनडायरेक्ट तो यहाँ से आएगा ना, तो इनडायरेक्ट इंग्वाइनल हर्निया इज गोइंग टू बी लैटरल टू इंफीरियर एपिगैस्ट्रिक आर्टरी, एंड दैट इज हाउ योर स्मार्ट एस रेडियोलॉजिस्ट नो, दे आर गोइंग टू टेल वेदर इट इज अ इनडायरेक्ट और अ डायरेक्ट इंग्वाइनल हर्निया। दे विल मैप द इंफीरियर एपिगैस्ट्रिक आर्टरी, सी द डिफेक्ट इज मीडियल और लैटरल। इफ द डिफेक्ट इज मीडियल इट इज योर डायरेक्ट इंग्वाइनल हर्निया, इफ द डिफेक्ट इज लैटरल इट इज गोइंग टू बी इनडायरेक्ट इंग्वाइनल हर्निया, सिंपल, ठीक है। सो दिस इज द बेसिक कॉन्सेप्ट बिहाइंड द कंपैरिजन बिटवीन द टू हर्नियाज, दैट इज डायरेक्ट as well as indirect inguinal hernia। If you put this diagram and if you write these 4 or 5 points, मजाल है कि एग्जामिनर 1 मार्क भी काट ले आपके, ठीक है। It is not possible if you are precise with their, see you have described the inguinal canal anatomy, you have described the sac anatomy, you have given the content, you have given the components, you have told all the complex difficult structures that need to be analyzed, and that is right in front of you, clear है, ठीक है। Now once you have the presentation, now we'll talk about the clinical features of inguinal hernia। So talk about the clinical features of the inguinal hernia। We'll talk about the clinical features of the inguinal hernia, right? So what are the clinical features of the inguinal hernia that you can think about, right? The first thing, how will the patient present to you? Now, the most common presentation would be of inguinoscrotal swelling. There will be presence of inguinoscrotal swelling. Now these scrotal swellings are usually painless. They are usually painless, right? So the primary complaint that the patient is going to come to you, it is going to be an inguinoscrotal swelling. It is going to be painless, and patient says that it varies in size. It varies in size. That means sometimes it is big, sometimes it is small. Now the minute you say it is varies in size, inguinoscrotal swelling, you know it is hernia, because hydrocele do not vary in size, right? Now I would like to examine. So the next immediate thing is going to be on examination. So on examination, what are the findings? So the first thing you have to tell your examiner that you know how to examine a hernia case. Now in which position which I would like to examine. Now commonly given wrong answer is going to be in a supine position. Remember, hernia should ideally be examined in a standing position, in a standing position after reducing the hernia, after reducing the hernia. Now remember, hernias are usually reduced in a supine position. That's also an important thing, ठीक है। hernia का reduction जो है supine में होगा, लेकिन examination will be in a standing position. So on examination, what are the findings that I'm going to get? The first finding I will see that as soon as I see that inguinoscrotal swelling, it is going to be a reducible swelling. That is, if I exert pressure, it is going to disappear. Now based upon if it is going to be granular, I can say it is omentum. If it gives a gargling sound and there is some resistance to reduce, it is usually bubble. Okay. Now it is going to be reducible swelling, number one. Number two, once you reduce it, you ask the patient to cough, and as soon as the patient coughs, the swelling will reappear. So there will be presence of an expansile. There will be an expansile cough impulse. There will be presence of an expansile cough impulse. It's a reducible swelling. There is an expansile cough impulse is going to be present. Now, once the swelling comes, based upon where it has reached, you can differentiate into 3 different contexts, right? Now, every time you examine the hernia, you have to tell that whether it is a bubonocele, whether it is a funicular, is it a complete variety, right? Now, if the swelling is going to be only reaching the deep inguinal ring, right? So just for the sake of understanding, if I give you the context, if this is the deep inguinal ring, this happens to be the superficial inguinal ring, and let's say this is the scrotum, and this is the testes which is present here. Now, once the hernia sac starts to descend, if the hernial sac is going to descend and reach only to the deep inguinal ring, not beyond this, this is called as bubonocele. If it reaches all the way to the superficial inguinal ring, this is what we call it as the funicular variety. Now, if it reaches all the way, if it goes all the way and reaches onto the scrotum, this is called as a complete variety, right? So based upon whatever I've described it, if it is limited to deep inguinal ring, so if it is reaching to deep inguinal ring, this is what we call it as bubonocele. If it reaches to superficial inguinal ring, this is what we call it as the funicular variety. And if it reaches all the way to the scrotum, if it reaches scrotum, it is called as a complete inguinal hernia. This is called as a complete inguinal hernia. Okay? So you have a reducible swelling. There is an expansile cough impulse is present, and when you try to palpate the superior extent of the swelling, you cannot, because it is inside the abdominal wall. So in inguinal hernias, you cannot get above swelling. You cannot get above swelling, right? Now, another thing, unlike like in hydrocele, there is transillumination present. Here, there will be absence of transillumination. There is absence of transillumination. There is absence of fluctuation sign. There is absence of fluctuation sign. There is absence of fluctuation sign, right? So it's a reducible swelling. There will be an expansile cough impulse. You cannot get above the swelling. There is absence of transillumination. There is absence of fluctuation sign, telling you that it is not a hydrocele. It is basically a hernia that you're looking at, right? So these are all the examination findings that you're going to be present. Now, on examination, one of the most basic thing that you should evaluate is to see the differentiation. It is to see the differentiation between the direct and indirect inguinal hernia. So on examination, you have to do something called as ring occlusion test. So we'll talk about the ring occlusion test. Now this ring occlusion test is done to differentiate between direct and indirect inguinal hernia. This is done to differentiate. Between direct inguinal hernia and indirect inguinal hernia. This is done to differentiate between the direct and the indirect inguinal hernia, right? Direct and indirect inguinal hernia. So how do you do a ring occlusion test, right? So the basic objective of doing a ring occlusion test, it's a stepwise approach. The step 1, what is the first step? The first step, it is to reduce the hernia. It is to reduce the hernia. What is step 2? After you have reduced the hernia, you have to occlude the deep inguinal ring. Occlude the deep inguinal ring with your thumb, right? Now, after you have occluded deep inguinal ring with your thumb, step 3, ask the patient to stand. Ask the patient to stand. Now, once the patient stands, step 4. What is step 4? Ask the patient to cough. Ask the patient to cough. Now, when the patient is going to cough, I will have 2 representation. Either the swelling will reappear or it will not reappear, right? So, see, you need to understand that before doing this maneuver, no, the patient would actually present it with a swelling that is in the inguinal-scrotal region. So, once you ask the patient to cough, I can have 2 results on cough. Either I can have a positive cough impulse or a negative cough impulse, right? Positive basically means that the swelling is able to appear even after occluding the deep inguinal ring. So that indicates that I am dealing with direct inguinal hernia. On the other hand, if the swelling does not appear, after occluding the deep inguinal ring, this indicates it is an indirect inguinal hernia. So all those intelligent people who are not able to understand why did this happen, so again the same analogy which is going to give you, let's say this in the context that we have already described it, no? So let's say this happens to be your external oblique aponeurosis, this is your superficial inguinal ring, this happens to fascia transversalis, is a deep inguinal ring which is going to be continuing across here, right? Now I am saying that all that you have to do is take your thumb, and after taking your thumb you have to occlude your deep inguinal ring. I have taken my thumb, and with the help of thumb I have now occluded the deep inguinal ring. Now once I occlude the deep inguinal ring, so I've reduced, see, first thing first, you have to reduce the hernia, right? So once I've reduced the hernia, now I have occluded the deep inguinal ring. Now once I've occluded deep inguinal ring, see, hernia has gone back, right? I have occluded deep inguinal ring. Now I'm asking the patient to cough. If a patient had an indirect inguinal hernia, the hernia will try to enter from here, but your thumb says thank you, goodbye, tata, you're not allowed, right? Because the entry point is blocked, so it is going to be a negative cough impulse. A negative indicates indirect. On the other hand, if you are occluding a deep inguinal ring and the patient coughs and the swelling is going to appear from here, now that means what? If the patient had a direct inguinal hernia, this is an indirect one, this is a direct inguinal hernia. If a patient had a direct inguinal hernia, you are blocking the passage of indirect. Lekin direct ka to path khula tha, so obviously it is going to come across. So on occluding the deep inguinal ring, if the cough impulse is negative, that indicates it is indirect inguinal hernia. But if it is positive, it indicates direct inguinal hernia. And this is what we call it as ring occlusion test. This is what we call it as ring occlusion test. Okay? Now, once you have performed the ring occlusion test, now you know whether you're dealing with an indirect or a direct inguinal hernia, right? Now, we'd like to examine it, right? So what are the investigations? What is the investigation with respect to inguinal hernia, right? Now, remember, hernia is a clinical diagnosis, and the only thing that I have to do in hernia is to differentiate between hydrocele and inguinal hernia, right? So the first thing you have to write that the first investigation that you have done will be a clinical examination. And you have to write hernia is a clinical diagnosis. You will write hernia is a clinical diagnosis. The other things that you can go ahead and do it, it is going to be an ultrasound of the inguinoscrotal region. Now this is to confirm that whether it is a hernia or a hydrocele. Now whenever you have a complicated inguinal hernia, this has to be dealt with CECT abdomen. Get a CECT abdomen if it is a complicated inguinal hernia. Now what are the complications that you can talk about it, right? So what are the complications associated with inguinal hernia? Complications associated with inguinal hernia. Now the first complications are going to be less severe, and we'll keep on adding the more severe ones. The first one, it is going to be irreducibility. Now this irreducibility is usually due to adhesions. So long-standing sac will have adhesions with the surrounding tissues, and that will not allow the hernia to reduce back. So irreducibility indicates some sort of either the ring is narrow, or the content is too much, or there is adhesion. So basically it is due to adhesions. Now along with irreducibility, it can have strangulation. It can also have obstruction. It can result in incarceration. And it can also have bowel perforation. Now, Strangulation is basically what will happen when the pressure in that area of the bowel increases. Now, to give you all the explanations for this, now the easiest thing that I can do is imagine that this is the sac that you have, right? And we talk about the content that is going to be present inside the sac. This is the content that we're talking about. Let's say this is the bowel that is entered here, right? We all know all bowel will have, let's say this is the mesenteric boundary of the bowel wall. This is the mesenteric part of the bowel wall. We all know the blood supply to the bowel actually comes from the mesenteric border. So if it is a blood supply, see the blood supply of the bowel comes from the mesenteric border, and as it comes from the mesenteric border, it is going to supply to every nook and corner of the bowel wall. So the blood supply comes from the mesenteric border. Now the concept is you need to understand what is strangulation, what is obstruction, what is incarceration, what is the bowel perforation. Now in order to understand each an individual whatever we discussed, let's say just for the sake of understanding, I'm just going to recreate this a bit. Now let's say this is the bowel that is present. This is the bowel wall, this is the proximal end, and this happens to be the distal end, right? This is the proximal end of the bowel, this is the distal end. Just to tell you, the content is going to move in this particular direction, right? Whatever content is there, it is going to move in this particular direction. Now what is an obstruction? Due to any reason, let's say the stools are getting blocked here. Now the stools are getting plugged. Because of this, the content which is supposed to flow in the forward direction is not able to flow. If a content is not able to flow in the forward direction because of some sort of an obstruction or some sort of an outlet passage difficulty, this is called as obstruction. So when there's an obstruction, any bowel obstruction will have same colicky pain, your nausea, vomiting, abdominal distension, abdominal pain, all that will be there. This is your obstruction. Now what is strangulation? Now once it starts getting obstructed, what will happen? There will be edema inside the bowel wall because it is getting compressed. Now when there is edema inside the bowel wall will now tend to swell up. Problem is, because it is in the sac, it does not have enough amount of space to swell up. So you will see as the bowel wall tends to swell up, it is now going to exert pressure on the inlet space. So the inlet is where the blood vessel is coming. If the blood vessel gets obstructed or gets compressed, the blood flow to the bowel wall decreases. So strangulation, the strangulation basically tells you that there is decreased vascularity. There is decreased vascularity of the bowel. Incarceration is called as impending gangrene. That means the ischemia has been for prolonged period. It is going to result in the gangrene of the bowel wall. And obviously perforation is nothing but because of poor blood supply, it is your ischemia induced necrosis, right? So in bowel perforation, it is due to bowel ischemia induced necrosis, and that necrosis will result in perforation, right? So if you write this and you describe it, nobody is going to take any marks away from you. Irreducible, strangulation, obstruction, incarcerated, and the bowel perforations, right? So these are the complications associated with that of inguinal hernia. If you have any of these features, always get a CECT abdomen done so that you can rule out these particular contexts. Okay? Now, how do you manage it? Now, management of the inguinal hernia. Now this table that I'm going to draw, no, if you draw this table, again your examiner is going to be super impressed. So when talk about management of inguinal hernia, the first thing you will think like a surgeon and write your answer. Now management of the inguinal hernia, you have to see whether it is uncomplicated inguinal hernia or is it a complicated inguinal hernia. Whether it is an uncomplicated inguinal hernia, is it an uncomplicated inguinal hernia, or whether it is a complicated inguinal hernia. Whether it is a complicated or a uncomplicated inguinal hernia, right? Now, once you know, we have talked about all the complications. Now, if any of the complication is present, right? For example, if there is obstruction, if there is presence of obstruction, if there is incarceration, if there is perforation, any of this. Now what you have to do is, you have to take the patient for exploratory laparotomy. You have to take the patient for exploratory laparotomy. In an exploratory laparotomy, if bowel is fine. When you're in exploratory laparotomy, you have to see whether the bowel is injured or not, right? If the bowel is not injured, then you don't need to do anything. You can go with hernia repair. You'll see the status of bowel injury, whether there is any incarceration or any necrosis or any gangrene. If the bowel injury is present, then you have to go ahead with resection and anastomosis of the bowel. You'll go ahead with resection and anastomosis of the bowel, and hernia repair should be done later. Hernia repair is going to be later. In an infected state, you cannot put the mesh, right? That is not allowed. On the other hand, if there is no bowel injury, then you can go ahead with hernia repair. So the concept here is whenever you have a patient who is going to have a complicated inguinal hernia, you have to see any of these obstructive features are present. If they are present, take the patient for exploratory laparotomy. On that, you see whether the patient has bowel injury or not. If there is no bowel injury, do a hernia repair. Otherwise, you have to go with resection and anastomosis, and the hernia repair should be different. If it is an uncomplicated inguinal hernia, then you have two options. Either you go ahead with open repair or open surgery, or you go ahead with laparoscopic hernia repair. You go ahead with laparoscopic hernia repair. Now, when you give an option of open surgery, in the open surgery, you have two methods. One, you can only opt for pure tissue repair. Another one is going to be mesh repair. So one, either we are going with tissue repair or we are going ahead with mesh repair. Going ahead with mesh repair. So when we say tissue repair alone, so what are the examples? Just remember the name of the surgeries that are going to be with respect to tissue repair. So in the tissue repair, you have shoulders, you have bassinis, you have Desarda, you have Melanie, Dan, and all that. Remember, these three names are important. Shoulders, bassinis, and Desarda are pure tissue repair. So when I say a pure tissue repair, in a pure tissue repair, you are not using any mesh. There is no usage of mesh, right? On the other hand, if we are talking about the mesh repair, here I'm going to use the Prolene mesh. So when you use a mesh repair, this is what we describe as Lichtenstein tension-free mesh repair. This is going to be Lichtenstein tension-free mesh repair, right? Now, the most common mesh use. So they will always expect you to tell the mesh material. When you are using a mesh, the material is important. The commonly used material, number one is going to be Prolene. Number two, it is polyester. And there is composite mesh. The most commonly used material, it is going to be Prolene. The most commonly used material, this is going to be a Prolene material. This is going to be Prolene material. Okay. Now, when it comes down to the laparoscopic hernia repair, so in laparoscopic hernia repair, you have to mention two techniques that are present. Two techniques in the laparoscopic hernia repair. It is going to be TEP and TAP. So we'll use two words. Number one is TEP, another one is TAPP. Now, what does TEP stands for? TEP stands for total extra peritoneal repair. That is total extra peritoneal repair. Then you have TAPP. TAPP stands for trans-abdominal. There's a trans-abdominal pre-peritoneal repair. It is your trans-abdominal pre-peritoneal repair, and this is what we call it as the TAP, right? So this is how you're going to talk about the various hernia repairs, right? Now, just to add the last thing on the icing on the cake, you have to describe 3 terms that they expect you to tell. What is herniotomy? What is herniorrhaphy? And what is hernioplasty? So 3 terms that is expected for us to describe. So when we say herniotomy, in an herniotomy, it is opening of sac in indirect inguinal hernia and reducing content. And reducing the content. When I say reducing the content, it is basically to push the content back into the abdomen. That is called as the herniotomy. You will not do herniotomy in a direct inguinal hernia, because in the direct inguinal hernia, we all know sac is formed of fascia transversalis, and fascia transversalis is actually a component of abdominal wall. So if you incise an abdominal wall layer, you're only going to cause weakness. What is herniorrhaphy? It is going to be only tissue repair. So in a tissue repair, so in herniorrhaphy, what do? You do herniotomy. If it is an indirect hernia, you'll do a herniotomy, and after that, we are going to strengthen the posterior wall. We are going to strengthen the posterior wall. Hernioplasty is usage of mesh, so it is going to be a mesh repair. So I'm going to do the same thing. You'll do a herniotomy, you will do a posterior wall strengthening, and then you will put a mesh on top so that it fixes across it. This is what we call it as hernioplasty. This is what we call it as hernioplasty. Now, never end your answer without writing the complication of the surgery that you have done. The last point is going to be post-operative complications. So what are the post-operative complications of inguinal hernia repair? The inguinal hernia surgery. So when you talk about the post-operative complications, so when you talk about the post-operative complications, number 1, it will result in acute retention of urine. Acute retention of urine, hemorrhage, injury to vas deferens, nerve injuries are common. Now when you talk about the nerve injury, couple of important things. Most common nerve injury, the most common nerve injury in open hernia repair, open inguinal hernia repair. On an open inguinal hernia repair, it is going to be ilioinguinal nerve. It is going to be the ilioinguinal nerve, right? Most common nerve trapped in mesh. Most common nerve trapped in mesh. So when you put a mesh, sometimes it can encase a nerve, and that is going to be the iliohypogastric nerve. It is the iliohypogastric nerve. The most common nerve injured in laparoscopic hernia repair. The most common nerve injured in laparoscopic inguinal hernia repair. Laparoscopic inguinal hernia repair, right? And that is going to be your lateral cutaneous nerve of thigh. It is going to be the lateral cutaneous nerve of thigh. This is going to be the lateral cutaneous nerve of thigh. Okay? So this is how you write your answer. So we started our answer of the inguinal hernia by definition. Then we spoke about the inguinal canal anatomy. Then we spoke about the difference between direct and indirect inguinal hernia. Then we spoke about the clinical presentation, investigation, surgical management, approach, post-operative complications, right? So this is how you're going to write your answers for inguinal hernia, right? So did we cover all the points that we have intended to? Did we cover inguinal hernia? We did. Complications in hernia and management did. A difference between indirect and direct inguinal hernia? We did so, right? So this is what you should know in the context of inguinal hernia, right? So far, any doubts, any questions, quick feedback? Okay. Aishwarya, if you are asking, sir, SRB or Manipal? Okay. If you have to pick one, I shouldn't be endorsing any of them. But then when we were in our post-graduation also, SRB is considered to be slightly more better because it is giving more, I will say, point-wise this thing. So if you want to prefer out of Manipal and SRB, go with SRB, right? If you want even better source, if you want to learn even better, then the answer is going to be Bailey and Love, right? There is no replacement for Love and Bailey. Every single student who is in the final year should read Bailey and Love, right? So there is no if and but. Just before the exam, yes, to brush it, revise it, you can switch to other books, but I strongly recommend to read Love and Bailey, at least the volume 2. ठीक है, वॉल्यूम 1 में चलो थोड़ा दिक्कत हो गया, वॉल्यूम 1 वी कैन यूज इट समवेयर एल्स, बट वॉल्यूम 2 हर किसी को पढ़ना है. दैट इज द ट्रू आर्ट ऑफ जनरल सर्जरी दैट. ठीक है, तो उसको नहीं छोड़ना है. क्लियर? ठीक है, कैन वी मूव ऑन? So the next topic that we're going to talk about is going to be pancreas. Pancreas में एक सवाल आया था, that is going to be acute pancreatitis. So we'll talk about acute pancreatitis. चलें? ठीक है. So one question that was asked in our exams, repeatedly asked from the pancreas, the question was on acute pancreatitis. So there were subparts to this question. They've asked you the causes of acute pancreatitis. They've asked you the clinical features and management. There is clinical features and management. There is complications associated with acute pancreatitis. Complications associated with acute pancreatitis. ठीक है? चलो. So our job is to address all of them. Again, in a single framework, we'll try to summarize all the answers. Again, as we've been doing this, again, if you talk about the marks distribution, the causes, the entire list was for 3 marks. The features and the management was 5 marks. Complication was 5 marks. There's a question which had a combination of both, which is going to be for 10 marks. Okay? So pancreatitis per se is important, especially when you talk about the acute pancreatitis, right? So when you talk about acute pancreatitis, let's talk about how to write the answer for this. So we'll talk about the answers for acute pancreatitis. Now when I say acute pancreatitis, it is defined as acute inflammation of the pancreas. It's simple, nothing more than that. So an acute inflammation of the pancreas. Now we need to know what leads or what causes this acute inflammation of the pancreas that usually occurs, right? So in an acute pancreatitis, let's look at the causes. What are the causes for acute pancreatitis? Now in the cause, the most important is going to be gallstones. In fact, gallstones happens to be the overall most common cause for acute pancreatitis. They are the overall most common cause for acute pancreatitis. The gallstone from the gallbladder falls into the common bile duct. From there it goes into the ampulla and blocks the ampulla, not allowing the pancreatic enzymes to excrete out, resulting in acute increase in pressure, inflammatory response resulting in acute pancreatitis. So gallstone is overall the most common cause for acute pancreatitis. Apart from gallstone, the second one is going to be alcohol. Alcohol is the second most common cause. Alcohol generates free radical oxygen. Those free radical oxygen goes and damage the pancreatic SNR cells, and then that disruption of cells will result in development of acute pancreatitis. Now, other causes that are important is going to be post-procedure like ERCP. ERCP stands for endoscopic retrograde. Endoscopic retrograde cholangiopancreatography. The endoscopic retrograde cholangiopancreatography, that is your ERCP. Metabolic disorders, example like hyperparathyroidism, hyperlipidemia. Hyperparathyroidism as well as hyperlipidemia. Now it is also secondary to the blunt trauma abdomen. So in the blunt trauma where there is pancreatic injury, and that pancreatic injury is going to result in the same, right? So there is gallstones, alcohol induced, ERCP, hyperparathyroidism, hyperlipidemia, blunt trauma to abdomen. There are infections which are important, certain viruses, Coxsackie virus. There is Coxsackie virus. Then there is mumps virus, and there is echovirus. All these viruses are also known to cause acute pancreatitis, right? Now, your examiner will be more interested in knowing whether you know the drugs that induce acute pancreatitis. Now, the list of drugs are important. Drugs that result in acute pancreatitis. Number 1, cytarabine. Antibiotics like aminoglycosides. Antiepileptic like valproate. Diuretics like thiazide. So cytarabine, aminoglycosides, valproate, thiazide, tetracycline, estrogen supplementation, pentamidine, trimethoprim, mercaptopurin, and the last one is aminosalicylic acid. Right? So these are the drugs which are known to cause acute pancreatitis. So the list is important. At least 5 you remember. If you can't remember all 10 drugs, at least remember 5 drugs that result in acute pancreatitis. Right? Now, in order to understand the pathophysiology of acute pancreatitis, it is going to be a huge disruption in the pancreas, which are going to present to you as symptoms. Right? Now, how does the patient present to you? We'll talk about the clinical features of acute pancreatitis. Clinical feature of acute pancreatitis. So talk about what are the clinical features of acute pancreatitis. Number 1, see, it's an inflammatory disorder. And inflammation anywhere in the body will have rubor, calor, dolor, tumor, right? So I cannot see redness. I cannot see the swelling of the pancreas. I can see that on an imaging, that is CT, but otherwise I will not be able to see. But the other two I can quite well appreciate, right? So when you talk about the clinical features of acute pancreatitis, if you have worked in casualty, it's like a small story that you have to remember. Any patient of acute pancreatitis will present to you. He'll present to you with sudden severe onset of epigastric pain. There is a sudden severe onset of epigastric pain, but it is not just an epigastric pain. If you talk to this patient, you will say that this is a radiating pain. The patient will tell you that this is a radiating pain. So where does it radiate to? Remember, it is going to radiate to the left side of the back. So from the epigastrium, it is like a band radiating to the left side of the back. Second thing, you will say, is there any precipitating or relieving factors? The patient will say that the component of pain reduces on bending forward. Component of pain reduces on bending forward. On the other hand, the component of pain increases on lying down supine. I hope you know the concept behind it. Just in case if you don't, I'll give you a quick component of why the pain is going to be variable in these patients. Now what happens is, if you have seen a patient, let's say this is the patient who's going to come. Okay? Now if you take this as a representation of the patient, and let's say this is the abdomen that is present. Okay? Now this is going to be a peritoneal surface which is present here. Pancreas, we all know it is retroperitoneal in origin, so it is retroperitoneal. Now right in the intra-abdomen you have the bowel that is present across here. Okay? Now what is going to happen is you will notice that this patient, whenever he comes in, he will not like to lie down supine. In fact, he will go find a nice wall, or initially he'll try to find a small stool, chair or table where he is likely to sit in this position where the patient would lean forward. This is the abdomen, and you would see the hands are tucked into the tummy, right? He is bending forward or leaning forward. On the other hand, if you say this is your chair and you don't want him to sit and you push him away, so he's, poor fellow, he does not have anywhere to go. So now he finds a wall. Now in the wall, he's going to stick his head like this, and then he's going to stand like this. He's standing in this particular position with the same reason. So why is he trying to bend forward or lean forward? The object is quite simple. As I told you, the pancreas are going to be retroperitoneal. When the patient bends forward or leans forward, the bowel is going to fall over the abdominal wall. Now, as you can see, the bowel is falling on the abdominal wall. The pressure on the pancreas is relieved. But when he lies down supine, the entire bowel is going to fall and sit onto the pancreas, which is going to exert more pressure. On inflamed gland, if you exert more pressure, the component of pain increases. So patient says, sir, I am fine bending or leaning forward. I would not like to lie down supine. So that's the first thing that you will notice in these patients, that is going to be with respect to pain. Now these patients will also be associated with nausea and vomiting. Now why there is a nausea and vomiting? We all know pancreas sits on the posterior surface of the stomach, and there's a nerve that runs through that is nothing but your vagus nerve. The vagal irritation due to pancreatitis will result in nausea, vomiting. So nausea, vomiting in acute pancreatitis is because of vagal irritation. It is because of vagal irritation. They will also be associated with non-passage. There will be non-passage of stools and flatus. Remember, every single intra-abdominal inflammation will result in a condition called as paralytic ileus. In paralytic ileus, basically the peristalsis cease, they stop, and the paralytic ileus is seen in every other condition where you have intra-abdominal inflammation. It could be colitis, it could be intra-abdominal abscess, it could be pancreatitis, anything. Any intra-abdominal inflammation will result in paralytic ileus, right? So there is severe pain, there is nausea, vomiting, there is non-passage of stools and flatus is the initial presentation of acute pancreatitis. Now obviously I would like to examine, so I would tend to examine. So on examination, what are the findings that you are expecting on examination? First of all, he won't let you touch, but somehow you are able to touch. What are the findings that you'll see? The first finding, there'll be severe tenderness. There'll be severe abdominal tenderness. There'll be presence of severe abdominal tenderness. Patient is going to have guarding. Guarding is not letting you touch. There's no rigidity. Rigidity is seen in peritonitis. Guarding is seen in severe abdominal pain or intra-abdominal inflammations, right? So there is severe abdominal tenderness is present. The guarding is present. Patient is not allowing you to touch. You auscultate with this test. There will be absence of bowel sounds. Now the bowel sounds are absent because of paralytic ileus. They're absent because of paralytic ileus. Now, because it's an inflammation tends to have friable tissues. They can bleed. When they bleed, they can present to you as retroperitoneal hemorrhage. They can present to you as retroperitoneal hemorrhage, and this is what we call it as the hemorrhagic pancreatitis. So in a retroperitoneal hemorrhage, there are two signs that you should know. One, there will be discoloration of the flank, and there is discoloration of the periumbilical region. So if there is discoloration, that is ecchymosis, or discoloration of flank region is noticed, and there is discoloration of periumbilical region, Flank, if it is discolored, this is what we call it as the gray Turner sign. Discoloration of umbilicus is what we call it as the Cullen sign. So ecchymosis of the flank is what we call it as a gray Turner sign. Discoloration of the periumbilical region is what we call it as Cullen sign. Okay? So on examination, these are the findings that you're going to present. Apart from that, because there is severe volume loss, these patients can also be in shock. So they can have tachycardia, they can have hypotension, and they'll also have tachypnea. So tachycardia, hypotension, and tachypnea indicates there is excessive volume loss, so patient may be in shock. So these are the examination findings, right? Now when a patient comes to you with acute pancreatitis, right, what are the investigations that you are going to run by the patient? Now here is the rule that I would like to tell you for any intra-abdominal pain. Okay? Any patient who comes with intra-abdominal pain, always start with the ultrasound of the abdomen. So the first investigation that I would do is going to be an ultrasound of the abdomen. See, USG abdomen is not a great tool because there's a lot of bowel chatter. There's paralytic ileus, the content is there only, the bowel is distended. So because there is distension, there is air. And because there is air, and you put an ultrasound probe, and whenever you send a sound waves in an empty space, it is going to resonate. And because of that resonation, what is going to happen? There will be a lot of disturbance that is going to be developed, or there will be a lot of echoes that are developed. So under that, there is pancreas will not be able to see properly. But again, USG abdomen can tell you whether the pancreas have become bigger or not. Bulky means edematous pancreas or not. Now, once you're done with the USG, you can also get an erect X-ray abdomen. Now, this erect X-ray abdomen, basically, see, when you look at the features now, they also look like intestinal obstruction. So what are the X-ray findings that you will see? On an X-ray finding, you can see presence of sentinel loop sign. There will be presence of sentinel loop sign. There will be presence of colon cutoff sign. There is a sentinel loop sign. There is colon cutoff sign. There will be renal halo sign. There will be this renal halo sign, and there is ground glass appearance. The sentinel loop sign, colon cutoff sign, renal halo sign, and the ground glass appearance. All these are present on an X-ray, right? But if I say, how do you confirm? Remember, the best way to confirm, it is going to be the clinical examination with lab investigations. Now in the lab investigation, two most reliable one, that is going to be serum amylase. You see there is serum amylase as well as serum lipase. See, both of them will be elevated in acute pancreatitis. See, amylase is also produced in the salivary gland, so which is specific for pancreatitis. It is the elevated serum amylase which is going to be specific for pancreatitis, You can also get the CECT abdomen. Now CECT abdomen is done to rule out hemorrhagic pancreatitis, as well as pancreatic necrosis. So whenever there is acute inflammation, it can also result in pancreatic necrosis. To rule out the pancreatic necrosis, you can get a CECT abdomen. So that is why we don't get the CT immediately. We'll wait for initial 4 or 5 days, give the treatment if it is not resolving, and that is when the best time to get the CT done actually, right? So these are with respect to the investigations associated with your acute pancreatitis. Now you have a working diagnosis of acute pancreatitis. Now once you have a working diagnosis of acute pancreatitis, how would you like to manage? So talk about the management of acute pancreatitis. So we'll start with the management. Management of acute pancreatitis. Now we talk about the management of the acute pancreatitis. But BLS में pancreas will take time now. Abhi, I think from this Monday onwards, that is from day after tomorrow, BLS we are starting hernia. ठीक है, hernia के बाद we'll go into GIT, और GIT में we'll start with the esophagus, and then we'll go into hepatobiliary pancreas is going to be in a later session only. I think June July तक हो जाएगा pancreas. चलो. Now in acute pancreatitis is excessive volume loss. So the stepwise management, the first one, I'm going to secure 2 large IV cannula. Start the patient on IV fluids, preferably ringer lactate. Start the patient on adequate analgesia. Right? So secure 2 large IV cannulas, ringer lactate, adequate analgesia. This is the prime finding that you'll do. Now most of them is going to have paralytic ileus, so keep the patient NPO, that is nil per oral. That means don't give any oral feeds if there are presence of paralytic ileus. Do not feed the patient, and in fact you have to do pancreatic rest. So ideally you keep the patient nil per oral. Okay? So you have to keep the patient nil per oral, start the patient on IV fluids, give adequate analgesia. Now once you have given this, I am going to wait for 24 to 48 hours. After 24 to 48 hours, I am going to repeat the complete blood count, and in the CBC, if the WBC counts are elevated. If WBC is elevated, then I will start the patient on antibiotics. Otherwise, there is no role of antibiotics to be given in acute pancreatitis. Majority of the patients respond to the conservative line of management, so you don't need to really worry about it. Okay? So this is how you're going to manage your acute pancreatitis in a conservative line of component. Okay? Now what are the for the assessment of the severity? For severity assessment of acute pancreatitis, you don't need to write the entire protocol for severity assessment. Just remember the severity assessment tools that we are going to use, right? For severity assessment, number 1, we'll be using Ranson score. Number 2, I'll be using Glasgow score. Or you can say modified Glasgow. We'll be using Atlanta classification. Then you have the APACE score, that is acute physiological and chronic health education score. Acute physiological and chronic health education, and obviously CRP, that is a C-reactive protein, are the ones which are going to look for severity assessment, right? You don't need to go and remember the entire Ranson's criteria, which is not important, but this is what you should look across. That is severity assessment. Now, what are the complications associated with acute pancreatitis? This will be our last point to summarize. Complications associated with acute pancreatitis. Complications associated with acute pancreatitis, right? So when we talk about the complication list, we'll be dividing the list of the complications into two. One, we'll talk about the local complications, another one is going to be systemic complications. So we have local complication, and systemic complication. We have the local complication and the systemic complication. The local complication and the systemic complication. Now, what are the list of the local complication that you have? In the list of local complication, number one, acute fluid collection, acute peripancreatic fluid collection, acute peripancreatic fluid collection, acute necrotic collection, acute necrotic collection, pseudocyst of the pancreas, Another complication is called as WON, which is called as ward of necrosis. It's called as the ward of necrosis. Because the tail of the pancreas sits into the splenic hilum, it can result two complications in spleen. Number one is splenic vein thrombosis. And number two, it is your splenic artery pseudoaneurysm. Right? So the peripancreatic fluid collection, acute necrotic collection, pseudocyst of the pancreas, ward of necrosis, splenic vein thrombosis, splenic artery pseudoaneurysm. It can also result in a fistulous communication between the left side of the thorax, right? So a pancreatopleural fistula. And that is usually on the left side. So it will result in less left pleural effusion. This will result in left pleural effusion, right? These are the complications with acute pancreatitis. Now, when you talk about the systemic complications, in the systemic complications, it is associated with SIRS, that is your systemic inflammatory response syndrome. Systemic inflammatory response syndrome. Resulting in sepsis, then going into septic shock. From septic shock, it can result in acute respiratory distress syndrome, that is ARDS, and eventually resulting in MODS and death. ARDS is acute respiratory distress syndrome. So systemic inflammatory response syndrome, sepsis, septic shock, ARDS, and MODS, right? So these are the complications, the systemic complications associated with acute pancreatitis, right? So this is all that you should know in the context of pancreas, right? So we have covered all the points which are asked for, right? So we spoke about the causes of acute pancreatitis, clinical presentation and the management, and the complications associated with acute pancreatitis, right? So these are all the questions that were there from your hernia as well as pancreas, which we have dealt. Okay. So for any questions, any quick feedback? anything that you would ask, or any other topic that you want me to take? These were the two questions that we have prepared for today. I mean, in terms of topics, so multiple questions we have covered it, but in terms of topics, there are two important topics that we wanted to cover. Quick feedback, any questions, any queries, कोई सवाल, कोई शक? Great. So if you have no questions, thank you so much. I think I'll resume another class because yesterday class I had an emergency OT, so I could not take it. So we'll continue with the previous part of the GIT with the next schedule on the Farre, and we'll take 2-3 more questions or 2-3 more topics for the exam as well, right? So thank you so much for joining today. We'll resume back with the next series or the next session on the Farre. Bye.